So Heidi's doing this one, and then for discussion, I said we should discuss this one. You want to do it, Yasmin? Oh, you're presenting later. Okay, somebody not presenting. Okay, how about Matthias? He's not here. Okay. Okay, so we can go to, okay, Vishnu's presenting, Yasmin's presenting, Sabrina's online.
Yeah, I can. I have some post-ops that might be trickling in soon, so maybe I can do this one.
Okay, oh, perfect. Okay, Sabrina, you do this one. Okay, so you can click forward here. You get this to go.
Thank you.
And then I'll keep this.
All right, so here's a case provided by Dr. Cohen. Thank you. So this is a 31-year-old female who went to his clinic in 2017 for just noticing that her vision was, quote, not right. When she checked each eye separately, she noticed a gray cloud in the center of her vision in the left eye for the past 1 to 2 weeks. So a little bit about her medical history. Just had a baby. It was born premature at 30.5 weeks because of early rupture of membranes and currently breastfeeding. Ocular history is that she's myopic, otherwise unremarkable, no pertinent medications. Her vision is 20/25 and 2100, and pressures are normal. Here's her color blindness photos. I'm going to take it away.
Okay, so the vitreous looks clear. The nerves look fine. There's a little bit of PPA. The vessels are normal caliber. The macula on the right looks normal. The macula on the left has an altered reflex. It's kind of hard to make out the details of what that is, but you kind of get like, you have the foveal light reflex that's a little blunted, and then around it, there's like this green artifact from the image, and then a little bit more of like what looks like a little atrophic to me surrounding that.
Yeah, I think it might be the computer or the program, I'm not sure, but on my laptop, it looked more grayish white rather than green. And then these spots as well are a little bit funky looking.
Okay. Cool. Okay, so now we have our autofluorescence on the left side. So you have your hypo-autofluorescence centrally with like a ring of hyper-autofluorescence around it, and then those spots that you pointed out all hypo-autofluoresce, and the ones at the bottom have a very small ring of hyper-autofluorescence around it.
Yeah, exactly. And I'm not sure if this is artifact, but there's looks like maybe a little bit of
Probably
hyper.
normal. The autofluorescent. Blue light autofluorescent.
Nice.
Okay, OCT of the right eye is normal. You have a clear vitreous, a good foveal contour, good outer retinal layers, and some PPA around the nerve.
Do you think they're myopic or hyperopic or emmetropic?
Probably she's a little myopic. I think we were told in the history and with the PPA.
Oh, okay, but in that choroid, the choroid also is.
You can tell how.
Yeah, because look how thin the choroid is. You can see the sclera, and it's a very thin
And the
choroid.
nerve is tilted a little bit.
Yeah,
Is that because it's stretched? So the choroid just like stretched?
yeah, the choroid thins out in the myope. So if you were to measure that choroid, it'd probably be 100 microns maybe, and it's supposed to be about 250. It's supposed to be about as thick as your foveal center.
Is there a term for thin
So
choroid?
that's, I'm gonna skip to the left.
Like,
Is it optochoroid? Do people use that?
That's an awesome credit I get. I don't know what people use. The opposite of fatty choroid.
They're starting to, people are starting to talk about choroid. I don't think they've landed on the term yet. Because there's pachychoroid for thick, so lepto, yeah. Okay, I like lepto.
Okay, so on this OCT of the left eye, the vitreous is clear. The foveal contour is attenuated, and centrally there's like subretinal hyperreflective material. And on the left side of that hyperreflective material, it looks like, I don't know, it's mixed. There might be a little bit of blood or something in there, because there's a small spot of hypo, a little bit to the right, Heidi, where it's like lumpy. No, yeah, there. Yeah. And then you don't see good integrity of the outer retinal layers, like the ellipsoid zone ISOS junction. And then you can see like the reflectance kind of shining through because you have those outer retinal changes. That's all I got for you. And then the vertical OCT of the same. And then on this one, it looks a little more pronounced, but on top of the hyperreflective material, there's like a mound of hyporeflectance. And I don't know if that's just like smushy normal retina or if that's something else.
This is sorry to distract, but what are all these little dark things?
Those are the acoustic shadowing after the vessels or behind the vessels.
Well, that's these.
Yeah.
But these guys here.
Like the vessels of the choriocapillaris?
Those are probably your short posterior ciliaries.
Okay.
You usually don't see them that well, but all your short posterior ciliaries are coming through the sclera. Because the patient's myopic. This is a weird OCT. Patient's very myopic. They also have their RPE is very thin. So you're actually seeing vitreous detail, retina detail, and scleral detail, which usually you don't see. And swept source OCT, eventually we'll see this, but in regular you don't. But yeah, you don't normally see the posterior ciliaries that nicely. Kind of cool. Anyway, it's not related to the case, although a little bit maybe. Go ahead. Just reading a paper on that.
So
okay, we have FA of the right eye. We're already past the AV phase. So far looks good. And in the left eye, so we're kind of in the laminar phase. And you can start to see some hyperfluorescence kind of surrounding the fovea, and then the line of hypofluorescence centrally. And then those spots again that we saw in the color images are hypofluorescent for now. And then centrally now we have hyperautofluorescence, and hyperfluorescence. It looks like it's pooling, but the borders are not sharp, so there might be some leakage there. Yeah, it looks like leakage.
Good. Yeah, it's a nice example of leakage. Perfect leakage. Which is interesting because your OCT didn't look all that leaky, did it? So it's one of the things you see sometimes.
Cool. And then I think I saw an ICG of the right eye. Looks normal, yeah. Okay, so we're kind of in the arterial phase and we're progressing through the laminar phase. And as we do that, you can kind of see like, can you go back one? Just, and then forwards again, that one. There's like in the superior fovea area, right around that dark ring, there's like a little tuft of maybe some inappropriate vessels, like some NV. I wonder if that will.
Yeah, I was looking for branch vessels, and you don't really see them. You know, I wish you'd saw more. You'd expect the whole thing to be sort of a nice vascular complex, but it's just not showing.
Nice. So here's a little summary of the findings. Sabrina did an awesome job. The fundus photo, the left eye, I said it was a blunted foveal reflex white grayish lesion. The autofluorescence, there's several hypoautofluorescent spots superior to the nerve that you pointed out. And then at the fovea, there's a ring of that hyperautofluorescence, and then the area of hyper infratemporally, also the macula. FA showed leakage centrally, and then the subfoveal or subretinal broad hyperfocal lesion.
So the top would be myopic CNV for this lady. I'm trying to think if there's anything related to her pregnancy. This doesn't look like a CSR or anything like that. I think I would keep the differential for CNV and the macula as the differential for this, but the top being myopia because that's what she has.
Nice, and that's exactly what I put together. So the top of the differential is myopic degeneration in CMV. PIC is another one, vascular AMD, less likely with her age, oculohistoplasmosis, PCV, CSR, like you mentioned, MACTEL, This goes on there twice, multifocal choroiditis, and then idiopathic CNV, or just, trauma related.
So what did we decide on the diagnosis with?
So you had sent it to me with either myopic CNV versus PIC.
If you go back to the pictures, there's,
And there's more
There's-
pictures that you
okay.
sent me, like a
Oh,
full
okay.
set.
so those spots, like the dark spots are,
Yeah,
are those lacquer cracks or are they PIC lesions?
I guess let's go back to the color. So they could be.
Yeah, they could just be little fuke spots, the old membranes, or it's hard to say. It's not it doesn't jump out at you. I think it's more myopic, but.
So, Dr. Cohen treated her with Lucentis monthly, her vision improved from 2100 to 2032 after 8 months of treatment. She had 6 total injections. Afterwards, she was lost to follow-up, but here on the OCT, you can see that the nice response. So that was initially when she first came in, what we saw. Then I believe it was a month later where she came back with some fluid. And then after that treatment, 2 months later, that dried up, but it looks like the scar was a little bit bigger. She was lost to follow-up, but then returned sometime this year.
And the only FDA approved treatment you also sent. Do you have that?
I think I have it in one of my slides, yeah. So she returned with vision loss in that left eye, 6 years later. Vision was 20/50. Measures were normal, so this is a color fundus photo of the right eye. Looks pretty similar, same PPA. I don't know if this area is like a new lesion or if it's just, more.
Yeah, it looks like a little different.
A little different from the.
She's older. I mean, you look under the nerve. I mean, it just looks like she's getting more myopic degeneration. I'm just looking at this stuff down here. That's all kind of like, if you look at that, she's kind of just thinning out like myopes did.
Yeah.
Like this is probably bigger than it was before.
Then in the left eye, so you can see a little bit more spots, similar to the ones she had before, but it looks more nasally there too.
Yeah, it's challenging because.
And then this area here, it looks like the grayish white lesion maybe spread superiorly as well. And then I think that pigmented spot is neat too.
How is this not posed? With the
The peripapillary. Well, it's not, there's not really peripapillary fibrosis.
Okay.
And the other eye looks pretty good, right?
Yeah.
So, yeah, I would go, but you could, I don't think you could.
You ask them where they're from.
And they're not really peripheral. The spots in ocular spasmosis tend to
Yeah,
be
you get
kind of
it.
equatorial,
Mhm.
and these are more posterior.
Okay.
But
But it
yeah,
could
you
be.
would want to know where she's from too.
Yeah.
She's from an endemic area. But yeah, you get more peripheral spots with the child.
But it could be, like you said,
Could be,
it could
yeah.
be. So what do you see there, Sabrina?
On the. Sorry, where?
Oh, autofluorescence.
Oh,
in
what
there.
image? Oh, yes, autofluorescence.
What's it showing?
So we see hypo autofluorescence centrally like we did before, but there's a new area of a kind of spot of hypo autofluorescence surrounded by like a plaque of hyper autofluorescence.
Good, thanks.
And then this OCT looks like it's also of the left eye, and I want to say it's a horizontal cut. And kind of similar to before, but that kind of darker gray mound is less. So there's hyper reflectance kind of subfoveally with like a little bit of hyporeflectance and attenuation of the foveal contour and loss of like the ISOS junction and ellipsoid zone. Okay. So this one looks maybe like a vertical cut. So all the way on the left side of the screen, I don't know if it looks just like maybe the hyaloid. That's
Yes, that's
still there.
Yeah, that's a myopic thing. So this is, the eye's starting to bow out a little bit, and you're starting to get that little tractional myopic thing,
Mm-hmm.
which I don't think was there before either.
And then subfoveally, there's a lot of hyperreflective stuff that kind of extends from right, I guess, at the umbo and more to the parafovea, perifovea. And then there's like a it looks like subretinal, like hyporeflective area. I don't know if that's like it's not a PED because it's not under the RPE, but a little hyporeflective spot. Okay, and FA. There are some hyperfluorescing spots that correlated with the second round of color photos that we saw. And so far, okay, maybe staining. And then this is the left eye. So the macula looks similar to before, and then that superior area so far is mostly hypofluorescing. And then, wow, surprise, all that leakage.
Nice. And these are nice examples of leakage.
What an unlucky patient.
Okay, so yeah, OCT comparing it from 2018 to 2023. Pretty similar, maybe a little bit worse in 2023. Okay, so I talked a little bit about myopia and the CNV related to that, but we know it's definitely PIC is in the differential.
Yeah.
But so high myopia is defined as an axial length greater than 26.5 or refractive error greater than -6 diopters. Pathological myopia is defined as -8 diopters or more, or an axial length of 32.5 or greater. And then, of course, you have to have the presence of structural changes due to axial elongation in the eye. So that could be like a staphyloma, the Laffer cracks, tilted optic disc, and even straightened and attenuated vessels. It is also recognized that CNV now related to myopia can occur at any degree. It doesn't necessarily have to be 8 or -8 or greater. So approximately 10% of patients with degenerative myopia will develop a CNVM over a period of 10 to 11 years. Around 30% of these patients also develop CNV in the fellow eye as well. Pathological myopia is the second most common cause of CNV after AMD, so always consider your differential whenever you see CNV. A little bit about the pathophysiology. So progressive, the axial elongation of the eyeball leads to chorioretinal stretching and thinning of the retina and choroid. The thought is there's Brace and Brooks membrane, like Dr. Fuller mentioned earlier, that induces VEGF. And then another thought is that the thinned out tissue is associated with poor blood circulation and then can eventually lead to CNV. So the symptoms that your patients will come in with are metamorphopsia, scotoma, decreased vision, if it's involving in the central macula. They can also be asymptomatic if it's in the periphery or outside the macula. The signs are retinal atrophy, appears as translucent defects, kind of what we saw that ring around the fovea, with clearly discernible underlying choroidal vessels. You can see Laffer cracks. You see those as hyperfluorescent streaks with transmission defects in the early and transit phase of FA, or like Dr. Cohen mentioned on the ICG, late ICG. CNVM appears as gray subretinal lesion with hyperpigmented borders, very similar to our patient. So the progression of myopic CNV, it's broken down to 3 main stages. So the initial phase, there's direct damage to the photoreceptors, and that's what causes the central visual loss acutely. Then as the CNV regresses, fibrous pigmented scars is left behind. Finally, the chorioretinal atrophy develops around the regressed CNV, which results in the poor long-term visual outcome. So management, Lucentis is, like you mentioned, the only FDA-approved anti-VEGF agent for myopic CNV, but Avastin and Eylea are used off-label. So here are some of the studies that looked at the treatment of myopic CNV. Repair and Radiance showed efficacy and safety of Lucentis in this condition. And then the PRN dosing of Lucentis was found to be superior to PDT in the Radiance study. I think the thought was people were doing PDT before,
Yeah,
like the anti-VEGF is,
your control arm can be placebo, yeah, can be PDT.
and the mirror study for EYLEA and myopic CNV in Asian population was found to be safe and effective. That was just something they found in their study. So follow-up for these patients, what I found on the AO was you treat and then the PRN regimen is the like most adopted, I guess, way of treatment for these patients. They're monitored every month for the next 3 to 6 months, and you evaluate your visual acuity, and then if you want with those ancillary tests. The criteria for retreatment are based on signs and symptoms of CNV activity. Like we mentioned, metamorphopsia, vision loss, evidence of new leakage on FA, and persistent or increased fluid on OCT. If there's no signs of active CNV, you can extend it to every 3 months during the first year. And then patients with myopic CNV, they usually respond pretty well and rapidly, and the recurrence is much less frequent than like wet AMD. I think that's all I have.
Nice, very good.